Then you move on to step 2 of the screening process. So here's the next step in the screening. And you can see on the left here, you're looking at impaired nutritional status, and points are given depending on the severity of nutritional impairment. And then on the right, you can see severity of disease is evaluated. So the sicker the patient is, the more points they get. These scores are tallied up, and then if the patient is age 70 or greater, they get an extra point because of the known risk that we see in older adults. And then if the score is a 3 or greater, the patient is deemed to be nutritionally at risk and a nutrition care plan is initiated. If the score is less than 3, the patient requires weekly re-screening to determine if they do need that nutrition assessment and care plan. The Nutrix score was developed in Canada by the Critical Care Nutrition Group, and this looks at more severity of illness factors to determine if the patient will benefit from nutrition intervention. And so they look at things like age, Apache 2 score, SOFA score, number of comorbidities, days from hospital admission to ICU admission, and interleukin 6 score. When there's a score of 6 to 10, the patient is determined to be at high risk, and they require nutrition assessment and intervention, aggressive nutrition intervention. If the score is 0 to 5, they're at low risk and do not need aggressive nutrition intervention. Not all hospitals can assess a Nutrix score, and so if that's the case, it has been validated to use this tool without Nutrix score, and you can see the scores here are just lowered by 1 point. So the high nutrition risk is a score of 5 to 9, low nutrition risk is 0 to 4, and this is still validated in multiple studies. So now let's talk about nutrition assessment. You've screened your patient, they're at risk, now they need that comprehensive nutrition assessment. So when you're doing your nutrition assessment, you're going to glean information from the medical record. So you're going to look at the current medical or surgical problem, relevant medical or surgical history, medications, anthropometric data, and the weight history, because we really want to look at unintentional weight loss. If you're able to interview the patient, you will look at diet history, confirm the weight and weight history, the use of vitamins, minerals, and herbal supplements, because this can impact your care plan. And then you will conduct a nutrition-focused physical examination. This clinical scenario of a patient in the ICU with multiple tubes and devices around the patient can pose a major challenge in your nutrition assessment process. So we'll talk a little bit how to work with these patients where it may be more difficult than your patient that you can easily interview and examine. So let's talk about some nutrition assessment challenges. It can be hard to determine if the height and weight are accurate. Are the weights in the weight history reported? Sometimes we see patients who have seen the doctor many times in the past year or so, but every single weight is the same, and that makes you think it's reported and just carried over from each clinical visit. Can you do a nutrition-focused physical examination? Most times you can, but there are some clinical scenarios where you just cannot examine the patient. So for example, a burn patient with multiple dressing on their wounds, you may not be able to assess all those muscle groups. So that can pose a really big challenge. Can you evaluate functional status? That is a part of that nutrition assessment. You may or may not be able to do, say, a hand grip strength. And then finally, how do you interpret your findings, and are there any confounders that you need to consider? So within the nutrition assessment, the nutrition-focused physical examination, it's valuable for all patients, absolutely, but it is especially important when you can't interview a patient. So when you're examining a patient on a ventilator, which are really the ones that we cannot interview, you might have some challenges getting to all the muscle groups. So you may work with the nurses to examine the patient's back during routine care. So when the patient's getting turned or cleaned, you may be able to look at the back to look for muscle wasting, fat wasting, and signs of micronutrient deficiencies. You usually can easily examine the temporal muscles, and you can slide your hands around the shoulder and upper back to feel the trapezius and deltoid muscles. You can palpate the pectoralis muscles. You can usually easily look at the quadriceps and patellar fat assessment. This usually can be done without equipment in the way. You can ask the nurses if the patient's wearing compression boots to prevent a deep vein thrombosis. Can those be removed briefly for gastrocnemius muscle evaluation? You want to think very carefully about the edema interpretation. Is this truly nutritional edema, or is this from some other reason? For example, the patient is post-op and required a lot of fluids during the surgery. You also want to look for signs and symptoms of micronutrient deficiencies during the evaluation. So patients who look like this, it's very clear they are malnourished and they need nutrition intervention, but identifying malnutrition in other patients that may not look so wasted can still increase the urgency of nutrition intervention. So now let's talk about malnutrition assessment. We'll talk about two tools. First, we're going to talk about the Academy Aspen Adult Malnutrition Clinical Characteristics. This was published in 2012. So using this tool, you need to assess nutrition risk. So use a validated screening tool to determine if the patient requires assessment. Then you're going to determine, is inflammation present? We know inflammation has a tremendous impact on the development of malnutrition. So if the patient does not have inflammation, we would use the clinical characteristics for starvation-related malnutrition. If the patient has mild to moderate inflammation, we would use the chronic disease-related malnutrition clinical characteristics for assessment. And then finally, if the patient has a marked inflammatory response, we will use the acute disease or injury-related malnutrition clinical characteristics. 6 clinical characteristics are used for evaluation. So we look at insufficient energy intake, unintentional weight loss, loss of muscle mass, loss of subcutaneous fat, local or generalized fluid accumulation that may sometimes mask weight loss. So this is your edema assessment. And then finally, diminished functional status is measured by hand grip strength. Only 2 clinical characteristics are required for malnutrition diagnosis, and then you work to identify moderate or severe malnutrition. So this is from a review paper that I just published with a colleague. And these are a summary table of the characteristics used to diagnose moderate malnutrition using the Academy Aspen framework. And you can see grip strength is not reduced in moderate malnutrition. Here are the clinical characteristics for severe malnutrition. And one thing I want to point out here is that grip strength is not recommended in the ICU setting for your critically ill patients. They usually cannot squeeze a hand grip dynamometer. So it's important to keep that in mind. I'm not going through all of these clinical